Right. Well, good afternoon again, everyone. My name is Casey. I want to thank you all for joining today's session. We're excited to have you all here and partake in our last exchange session for 2025. And we look forward to today's session and hearing from you all and updates on your recognition programs. But before we get started, we would like to acknowledge that the EMSC Innovation and Improvement Center is funded through a cooperative agreement with the Health Resources and Services Administration, which is within the U.S. Department of Health and Human Services. As a cooperative agreement with the federal agency, the EIC must adhere to executive orders and related federal guidance. Additionally, the contents of today's presentation are those of the authors and do not necessarily represent the official views of nor an endorsement by HRSA, HHS, or the U.S. government. And as a reminder, our session is being recorded and will be made available on the PRRP Exchange webpage. So we hope for you all to participate in today's discussion, having your cameras on, asking questions of one another, and sharing resources. So we do look forward to hearing updates from a number of our participants today. You can, again, use this as an opportunity to learn from one another and exchange ideas with your peers. So I am going to go ahead and have us get started with these today. I have some presentations loaded if you would like me to share, or if you would like, I can hand over control to you all when it is your turn. So I don't believe we have anyone on from California. Didn't see anyone list. No, if we have folks on from Connecticut today who would like to share an update.
Hi guys, it's Megan. I am going to apologize to the group. I've been a little out of commission for the last few weeks, a couple surgeries and some complications. So I unfortunately don't have anything to share today, and I'm so sorry.
Thank you for being on today. We look forward to hearing from you during a future session. Right, and then don't think I saw Maryland on. Does anyone from Maryland want to share an update today? We do have Kelly from Montana. I have your slides, or if you would like, I can hand things over to you.
Well, that escalated quickly to me. I guess you can go ahead and share the slides, please.
Okay. All right, I'll hand things over to you.
Thank you. I'll turn my camera on too. So this is similar to the same presentation I did last year. Since I presented last year, our pre-hospital program has been unverified. So this is the only verified by HRSA program we have, which is our hospital program. Next slide, please. So our verified program was started in 2016 with a couple of like trauma 2 medical centers. And then 2017, we went to all of our major medical centers in Montana, if you call it, which is like 6, 7 hospitals. And at that time, we determined 2 levels of recognition. Some are level 3, most are trauma level 2 and 1. Our pediatric prepared, which has more like in-depth criteria, and then capable, which is mostly critical access. But we also have EDs that have even a lower trauma level, which of course would be pediatric capable. And then our application is one application, but we have columns for prepared and capable. So the applicant just checks which one they're applying for. And that mirrors our state trauma designation review process for what level they apply for. So currently, as of today, since its implication, there's 19 recognized EDs. We added 1 new this year, and then the rest were renewals. We have a total of about 65 EDs in the state, including IHS facilities. 8 of them are pediatric capable, which is again critical access and below, and then 11 are trauma levels 2, 3, and oh, there's a typo on my side, I see. So levels 1, 2, and 3, and we have 2 trauma level 1 hospitals as of just last year. So Montana is extremely rural. I think everyone on the call is probably aware of that, but I can't emphasize that enough working in the health department that we have a lot of challenges with rural healthcare. All of the hospitals that have been recognized are listed on our state website, and the link to our state website is there. And it's broken down whether it was capable or prepared. Next slide, please. So I just added, if you go to that website, since I'm in a Department of Health, I don't manage my own website. So sometimes I think people might look at it and be like, wow, you don't have much on there, but I don't have control of what I post on there. So Rachel, who's on the call, has helped me out with some stuff, because it also has to be, it's on me, the program person in my department, to make all the documents accessible, ADA accessible, which is a huge task. So our actual criteria application is on a request basis, which works well, not just because circumventing the web editor issue, but also too, it kind of just knows, it makes it a bit more serious, someone's level of interest. Like if I'm actually going to email them our application, then I've spoken with them enough, they've reached out to me. But at the link where the application packet is, there's our application instructions, a form that we have to identify people that can be invited to the call. I've heard in other talks that people have done. In our hospital recognition, we always try to include pre-hospital. So we always invite them. We always invite the C-suite, but we don't limit actually doing a visit if those people aren't present. But that kind of answers, that document answers the question of who we invite to the visit. And as I said, our actual criteria is available on request. I should add our application criteria is actually two documents. It's our recognition criteria document and a disaster preparedness checklist. I think Montana was an early adopter of that, and we have contracted with a former hospital emergency planner who is a paramedic that oversees that aspect of the checklist. So we have a very robust disaster preparedness component in our recognition. Next slide. So for verification, we haven't changed it that much throughout the years. It seems to work mostly, but I've joined all of these calls that we've had. You guys are probably all familiar with me, just hearing how other states do it, how it can be improved. Seems like there's a lot of variation. So we've stuck with the format that we have. That doesn't mean it works great, but it means it works. So we're always looking to improve. So the team, because of funding, which is always a question asked, appropriately so, I don't have any other funding. So I use the program grant to fund, as I said, the disaster preparedness component of the program. He does other stuff too. That isn't true to say he just does that. He's our contracted paramedic, again, emergency planner, and I don't think he's on today. I didn't see him. His name's Jason anyway. And so we do the site visit in person. With obviously not having funding this year, we pivoted to virtual. Now that we have so many facilities that are, especially our large hospitals, like in our trauma 1 and 2s, they're renewing now on a 3-year cycle for 4 and 5 times because they were initially verified back in 2016. So we're also exploring just doing that virtual at that point, because again, it's not an initial review by any means. One thing that we did really focus on kind of tweaking in this process, and again, it's all documented in our application checklist. I've heard other folks say this too, especially with the amount of policies, procedures that have to be submitted and reviewed, especially if it's an initial application. We have them submit that to us, and I gave a deadline of 2 weeks. It kind of just makes it clear that we as just myself and one other person have time to actually review everything. I think it also gives a bit more teeth to the process, saying we have that deadline. So we review all of the returned checklists, which is again the recognition criteria and the disaster checklist, along with policies and procedures, just emailed copies of them. Typically way more than 2 weeks because it's so much stuff, but with a deadline of 2 weeks. And then we focus on the site visit, which is in person, like I mentioned. So we do like an entrance interview, we go over our findings on the checklist, and then we end it with a walkthrough of the ED. But because it's also a very large state and it costs a lot of money to travel, it requires overnight travel. Montana is a resort destination state. So for folks, yes, I can share the checklist. I'll put it in the chat. Thanks, Rachel. For people that come here, I think they get sticker shock. We have a resort tax. I shouldn't say resort tax. We have inflated travel for hotels, etc. So we're looking at, in the summer, potentially $400 a night for a motel for myself and my contractor. So realistically, I don't think that's sustainable with the funding issues that we've had. So that's something that we're talking about internally, maybe just pivoting to a more virtual component. And then trying to plan travel when it isn't like going to be July and we're getting these inflated costs. Yeah, I added that there. So due to funding limitations, we have pivoted to virtual. And I think it was like 3 or 4 during the time that we did virtual. Everything else has been in person. Next slide, please. Verification is done through all of the things I just said, doing the checklist, doing the in-person visit. I see people doing comments. I can't read them right now. I'll do after I'll post it after I'm done with this. But so we do the in-person part. Well, they do the checklist prior, then we go on site. On site, we don't say right away if you're verified or not, because of course, if it's a new facility, we could find something on the ED walkthrough component, a Broslow card, etc., like that. But for the most part, we already know that they're going to be deemed ready. We've done the pre-work reviewing all their applications. But then within 30 days, I'll contact them and let them know. So then we submit or we provide to them a recognition certificate. I see it around hospitals. People post that, or certificate of recognition. We publish we have a press release. We really encourage hospitals to share that with their local media, and they do. They like to share the great work that they've done. It also kind of works as promoting the program. If they don't choose to do the press release, we have a memo with, again, dates that they're certified, renewal dates, kind of an overcap of what pediatric readiness is, that it is valid for 3 years and they have to reapply in 3 years. And then I send that in a hard copy, but I also put that in an email. Next slide. EDs are engaged through, I think that may be an advantage to being a rural state, is we do have really robust communication systems. So I actually have access on the pre-hospital side, but also with my colleagues on the hospital side, to listservs of essentially all of the trauma coordinators in the state, and then every licensed EMT in the state. So we have we use Gov Delivery, but we have listservs through that, but primarily through the newsletter that I put out monthly. That'll be the main, I think some of you actually receive that newsletter. That'll be like the main at the top if any hospital or in the past any EMS agency was verified. And then we also have our obviously the EMSC Advisory Council, I'll announce it, but we do an EMS newsletter, and that's definitely included in that, which goes to every licensed, even if they're not working, every licensed EMT in the state. And then we have an annual trauma symposium where we announce it at. We have a Facebook group, a PEC Facebook group, which is primarily EMT, but there are some hospital staff on it. And that's primarily, I meant to add a couple things, but Yeah, and then we have trauma designation meetings bi-monthly, and it isn't always announced there if a hospital is verified, because it's usually a large agenda, but I add it when I can. And I think that is my last slide. Go ahead, Casey.
Thank you for sharing, Kelly. What questions do you all have for Kelly?
And I will put the
Yeah.
application is on the website for the disaster preparedness. I'll post it. The recognition criteria isn't. Like I said, I have that as available upon request, but I can post that as well here.
Thank you for sharing those. What questions do we have for Kelly? Feel free to come off mute or raise your hand in the chat. Melissa.
I didn't design the preparedness checklist. This was my predecessor before I was here. And I believe they worked on this with Illinois, if there's anyone from Illinois on this, the specific disaster checklist.
Dwayne, what's your question?
And everyone's asking me to share stuff. I mean, the quickest way would just, I'll put in the link to my website.
So my question, Kelly, is, you have, I think you said 19 recognized and 65 hospitals total. What do you
Yep.
think the barriers are for those hospitals who haven't applied to the program? That is it something on their end? Is the program's too detailed for them? What are your thoughts?
It's a great question, Dwayne. You know what? Honestly, a barrier this year has just been the program and me. Just not knowing where we stand with it, and then the limitations of what having one person can do is. It's a huge state. So all of these promotional, the far corners of the state, one person can't do all that communication. So that tends to be more who falls through the cracks is Rachel Alter can verify all this for me. I mean, we have 700 miles. So the persons in the far corners of the state, I don't typically travel there, and vice versa. If we, again, it was like email channels, the Gov delivery is probably the best one. But it's not a situation where I'm like encountering these people in a room at one time. So just getting their engagement through email communications. That being said, some folks that do live far away, maybe that's just a personality type of someone. They're very interested in it and they're outgoing. But as far as the larger cities, that's where we have the most presence because, again, I'd be networking with them. But it's an overall limitation. I mean, you bring a great point because, again, I know a lot of people say, like, you don't have any other staff. So I guess I would kind of answer your question with a question too and say, I'm open to other people's suggestions because it seems like to do more outreach, there gets to be a point too where you're going to have to be looking to partner with someone, other programs, stuff like that, to kind of look outside just this program. And I do work with I'm lucky in that fact too, that our trauma program is in our office. So that's mainly where I do a lot of the work with them. But as you guys know too, the trauma program for states well, maybe not all states. In our state, it isn't a requirement as well either. So there's some facilities that don't participate in anything. So does that kind of answer your question?
Yes, thank you.
Kind of a long-winded answer, but yeah, definitely the ones that I engage with the most are like our larger cities, just because I go to a conference, etc., stuff like that. And there's more staff in those facilities that they can send their staff to opportunities like that. But the really small rural ones are really hard to engage with.
I wonder if there's anyone on today's call who maybe has had success in reaching out to like some distant rural sites or has found ways to reach them that have been successful that you could share. Or thoughts you might have to approach it. Well, you might think that over there was another question in the chat for you, Kelly, about your Facebook page with the PECs. Like, what type of
Yeah.
information are you sharing with them there?
Yeah, so I'm trying to post the Word doc. Can I not post that into Zoom?
Let me make sure I'm not.
Let me post it. So the Facebook page is maintained by our by the program's pediatric liaison, and it's very heavy on, so we do post like any hospitals that we verified, especially any EMS activities. It's more EMS focused really, just because that's a larger group of people, but it's very heavily we do a lot of like disaster preparedness, school safety, just really anything along those lines. I don't think it gets great engagement, to be honest. I mean, there's a lot of, there's a Facebook group for everything. So it is a private Facebook group, but there's been a lot of people that follow it for years now. So I don't maintain it, like I said.
And then I did adjust a setting, so you might be able to upload that document now.
Okay, let's try it again.
And then question or sort of a comment from the chat, wondering if your rural CAHs are associated with larger hospitals in your state.
Sorry, Casey, I still wasn't able to post it, and it gives me a weird, it says it's in use, currently in use.
Okay, well, if you want to maybe email it to me after the session and
Okay.
I can distribute it for you.
And I'm sorry, could you repeat the question?
Question is if the hospitals are associated with like a larger hospital, if your rural sites have
Yeah.
network.
Yeah, yes and no. But yeah, definitely that's a great point, Corolla, especially that is a trend that's happening very much. I know it's happening where the larger hospital is kind of eating up these smaller ones. And actually that really does help with our pediatric readiness. Some of the staff may not like it, but especially like our really large facilities in Montana are and they're not exactly buying the critical access hospital. They have the critical access hospital might exist as like a nonprofit and they're in partnership with them. But that really helps with their policies and procedures because then they have contacts in the larger facility. But some of probably most of them are in a larger network, but some of them are still standalone.
Back in the chat.
And I saw Rachel said, I keep telling people there's nothing to see here in Montana, but no one believes me. Yes, I always feel like saying that too. And someone said, can you share your press release? Sure, I can share the template. But again, it looks like I can't post Word docs in here for some reason right now.
There's also templates for press releases in the marketing materials on the PRRP resources page. I don't know, Amy Myers, if you want to link that in the chat for folks. All right. Thank you all for some really thoughtful questions. If there aren't any others, don't think we have anyone on the call from Nevada today. Try an update. Next up, I have Ohio.
Yep,
Kyle, same thing. I have your
that would be
slides
me.
ready for you, or I can hand it over to you.
Yeah, if you can just keep the
Alright.
slides on your end, that'd be great. Thank you. So yeah, again, everyone, my name's Kyle Smith. I'm the program manager for Ohio. I'll be focusing on our emergency department pediatric readiness recognition program. So just a broad overview, our recognition program was launched in late 2024 by my predecessor. I started in the role in late June of this year, so almost 5 months I've been in it. But since that time, we've received a total of 6 applications. I think I had that on the next slide. Most recently, though, we did complete our very first site visit this year in November, just about 2 weeks ago. So very exciting for our program in general. And we look forward to that potentially being the first recognized hospital in Ohio through our program. We do offer 3 tiers. So at the pediatric ready, advanced, and comprehensive level, at the bottom of the screen here, I have some of the key differences between each of the 3 tiers, some of which depends on, for example, your NPRP scores. So ready and advanced, we require a minimum of 90 points, and then comprehensive, a minimum of 95 points. So um, it can be a big ask for some facilities, but again, it's our goal, of course, to make sure that every facility who applies and receives recognition is as prepared as possible to handle a pediatric patient. Some of the other key differences include at the ready tier having a shared PEC, so it can be a physician and or nurse shared between multiple facilities, especially some of the rural portions of the state. Advanced tier, however, we require a dedicated PEC, either a physician or nurse. And then comprehensive, we require both a dedicated nurse and physician PEC. Related to like trauma centers, comprehensive tier, the facility needs to be a level 1 or level 2 trauma center, and also have pediatric intensive care unit, neonatal intensive care unit, and also 24-hour pediatric coverage for nursing staff. And again, of course, based on ready, advanced, comprehensive tiers, each one kind of builds on the other. So ready tier would be the foundational level, advanced would be that middle tier building on some of the ready tier requirements. So whether that's related to policy and procedures, especially, and then comprehensive, of course, is most comprehensive, having as many pediatric related policies as possible. In addition, we also require certain support service capabilities. So for the ready and advanced tier, having point of care testing available, and then the advanced tier having full-time 24-hour laboratory as well for testing. So we try to make this as inclusive as possible, no matter what type of capabilities the facility has. We like to highlight that there is a tier that best fits your facility in order to be pediatric ready to a given degree. The next slide, please. So again, as I mentioned, we had a total of 6 applications received so far, all of which across the 3 tiers, and we do have interest growing within our program, which I'll further on the next slide. Our application process is around 7 to 8 months long. Ideally, again, it's pretty comprehensive before we reach the site visit phase. So first and foremost, a facility would submit their application, requiring like C-suite personnel, nursing or physician management, ED management, to sign in a test that they meet the capabilities of the given tier that they're applying for. At that point, an introductory call is held with myself and my leadership team as well, but those of the facility, in order to give an overview of Ohio EMSC in general, and then the application process further in depth. Throughout the entire process, we offer guidance throughout for the submission of required material. What we have recently implemented is called a supporting documentation form. So it's several pages long, but each piece of criteria that we require based on the tiers listed throughout there. We try to sell it that it's a more streamlined and organized approach. Prior to me joining, the process was having facilities essentially send a list of their policies, procedures, any sort of documentation material related to the requirements. They would email it to us and kind of just ask us to parse through, some documents that are 10, 15, 20 pages long, looking for, 1 or 2 specific lines of criteria that we're looking for related to their policies. So we felt that any facility who is applying for recognition, needs to be putting in the work diligently to, explain and show why and how they are pediatric ready. So again, this new form or document is a bit more organized. It lets each facility list exactly what documentation, sites, whatever criteria they're looking to meet. And then it ultimately makes for our review a much more seamless process. After all the materials are submitted, I review them, and then we go through a pre-site virtual meeting with myself and Ohio EMSC leadership team to set the site visit expectations with the facility, as well as going over any remaining documentation that might need clarification or submission. From that point, we do give the facility a 30-day or advance notice of the site visit in order to allow them to prepare, make any sort of like staffing adjustments, uh, gather all their documentation to have physically available. And the site visit itself is led by a total of 3 to 4 facilitators consisting of program leadership, so whether that be myself, our program director, or members of our emergency department recognition committee who votes on the final report that's submitted by our facilitators following the site visit, which essentially is a complete report of every piece of criteria that we're measuring or assessing, with strengths, gaps, and opportunities listed in that. So again, our recognition committee would review this report in full, and then we would cast a vote amongst the committee. And this ideally would take around 8 weeks from the post-site visit date to when the decision is communicated with the facility. So again, this is what we're following. We haven't reached the recognition committee phase final report review yet. Again, I noted that our first site visit occurred about 2 weeks ago. So myself and our program leadership are working on that final report to submit to the committee for a vote. And then hopefully by mid-January is when we'll be able to communicate with that facility that they hopefully received recognition. So next slide, please. So again, kind of going further in depth with the overall recognition program verification, the pre-site visit, the facility submits their policies, procedures, process material. I myself, as the program manager, I summarize that criteria alignment for facilitator review prior to the site visit. The in-person site visit, again, we'll have 3 to 4 facilitators, including a lead facilitator who would be a senior physician, someone with tenured clinical experience to kind of lead the other 2 to 3 facilitators. We kind of have a unique process where we have 3 different facilitator or reviewer roles. So initially, when we arrive at the facility, we would meet with any of the emergency department leadership, C-suite, et cetera. They provide a SWOT analysis of their facility related to their facility capabilities and also their most recent PRRP assessment. That's around a 30 to 45-minute process. And then from there, us as facilitators split into chart reviewer, tabletop reviewer, and rover reviewer, as we call it, role. So the chart reviewer remains in the main conference room, reviews pre-selected pediatric patient charts with members of the emergency department, assessing for certain policies that we require. The tabletop reviewer will do staff certification checks, so checking for board certification and licensure, and importantly, PALS or APLS licensure amongst all nursing staff, advanced practice providers, and physicians. Then a rover reviewer conducts a walkthrough of certain parts of the emergency department, as well as support services like radiology and laboratory, and then also assessing for functionality and accessibility of certain pediatric-based equipment within the emergency department. Those 3 separate reviewer roles are 90 minutes each, and from there, the 3 of us regroup in the emergency department to conduct what we call a policy to practice scenario. So it's a 45-minute discussion or lightly verbal and demonstrable discussion for a mock scenario. So for example, some sort of disaster response, say a pediatric event for an apartment fire where a facility were to receive a surge of several pediatric patients at once. So we have a predefined scenario and about 10 different prompts kind of walking the facility through from start to finish, from the time that they're notified of pediatric patients en route to their facility through some of the initial triage pieces, and then post review as well, what that looks like. Again, post site visit, facilitators will complete a final report, to which is then submitted to the recognition committee for a vote. And then from there, the facility is provided the decision of recognition, and they also receive a summary of overall strengths and opportunities from our site visit. For our first site visit, we received multiple demonstration or compliments throughout from the facility regarding how collaborative of the process it was. We try to sell it as it's not punitive but positive. And again, we were glad to see that kind of our new means of verifying the site was a success and positively embraced by this facility. Again, 0 facilities have been verified so far, but the first verification may occur in either late December or early January. The next slide, please. Finally, some of our marketing strategies. So webinar wise, myself and Dr. Charles McCombs, he's Ohio EMSC's lead for emergency department pediatric readiness. Is his official role. He sits underneath our program director. Him and myself have held monthly calls or webinars in September and October, reaching around 60 overall or 60 total facilities in Ohio, really to sell the benefits of pediatric recognition, and for facilities who may not be quite ready yet to apply, provide them with resources and what that overall process looks like in order to prepare for the future. We are experimenting with a application cycle, so our next application cycle will open in December, and again, we have kind of defined a 7 to 8 month process from start to finish. That's been one of our big challenges so far with facilities who are in progress or in the process of applying, some of which have applied close to a year ago and are still in the process of submitting documentation. So by creating a defined process for when they need to submit their material for review by, ideally we'll keep them on track and kind of prevent the overall document submission process from falling into the cracks or getting in the way of other things, competing priorities. I mean, every facility has them, but again, it's our goal to, recognize you as efficiently as possible as well, and make sure that pediatric readiness stays a priority even during the application process. Targeted outreach as well. We monitor NPRP scores near or above the tier minimums and do direct outreach to those respondents just to praise them, especially for those who have NPRP scores of near 90 to 95 points, and encourage them to research further into the recognition program or process if they haven't further or previously been aware of Ohio EMSC and the recognition program. So again, direct outreach right now is another one of our big means of at least identifying facilities who we think would be good applicants, quote unquote, to apply for the program. Social media wise as well, when I started back in June, overall we only had around 100 total views across the 3 platforms, and now most recently in October 2025 we have almost 5,000 monthly views across 4 social media platforms. So the way I look at the program is you're kind of like running a business. What exactly are you selling to these facilities, which is, in this case, the hospital or emergency department recognition program. How are you selling that? How are you marketing it? And again, like any business, what the benefits are of, not in this case, not purchasing it, but, embracing the program. What benefits do they get from applying? Which, there are many. I could go on all day about the benefits, but again, that's our marketing and outreach strategy. So far, we've found success in it, and obviously, we look forward to continued success in it. Again, I kind of one of the comments Kelly made is that being only one full-time person for the program, it is hard to, balance competing priorities, like I said. So again, just remaining efficient and allocating your time to certain parts of the program. So having what I do is just blocking off a certain part of my schedule each week, and making sure that's clearly defined and devoted to our ED readiness, or that's through outreach, whether that's through following up with current applicants, reaching out to future prospective applicants, etc. So yeah, I think is that my last slide, Casey?
Yes. Thank you so much
Okay.
for sharing, Kyle.
Yeah, thank you.
What questions do you all have for Kyle? You see, we had one in the chat. I don't know, Dwayne, if you wanted to.
So my question
Follow
is
up.
kind of a couple of questions. Who does the chart review, and do you have any specific qualifications or role that qualifies them for that? And what documentation do you include to address the HIPAA compliance, as that reviewer is most likely outside of the healthcare organization?
Yeah, so our chart reviewer is whoever the most senior physician is who would take part in the site visit. So for this first one, it was our program director. He's been a physician for the better part of 20 years. Granted, she knows exactly, what she's going to be looking for in that chart review. I can share what our chart review looks like, but our program is housed through Nationwide Children's Hospital, so we've been able to utilize their legal team to make sure that it abides by any sort of HIPAA compliance. It's also a de-identified form, so we aren't documenting, patient numbers, patient names, any sort of identifiers. After the site visit as well, we provide the facility with a copy of the chart review. Really, it's just, age level, ESI level or category, and then, depending on the type of chart review that we're assessing for certain criteria, based on each recognition tier, we're looking for in that chart. So if it's a pediatric behavioral health chart, we're going to be looking for certain pediatric behavioral policies to be listed in there. And then, so like that, say, was family-centered care documented, yes or no? Were, vital signs documented, yes or no? Reassessment, those types of criteria or categories we're assessing for. So all of our forms we've made sure are HIPAA compliant, and again, we try to be as completely as transparent as possible to each facility. And then with this, we've realized the need for certain liability agreements, not only for our site visit reviewers, but for the facilities themselves. Again, just to maintain and abide by that HIPAA compliance.
Kyle, I just had more of a comment, and kind of going back to Dwayne's question for me.
Mhm.
I mentioned that we use Gov Delivery in our offices here. It's a lot of like government, it's for governments, Gov Delivery, right? But that your social media, like that's a really key point. Again, if you have time and resources to do it, but just seeing like I can track analytics. So that's another really good, like when the NPPR comes up, like, well, sometimes you find too, like the person you can kind of sleuth and be like, well, my communications are going through, they just don't seem to be interest. But that is kind of how you can tailor it too, with like, obviously you can see hits on Facebook, but if you have something to track analytics, because again, if it's voluntary, I mean, you can only ask a person so much, you can't.
Yeah, I mean that's the big thing. It's a voluntary program within Ohio, so that's why we have to try to sell it as best as we possibly can. I mean, there's there are competing verification processes and programs out there. So I mean, that's one part of it, but um, again, it's really just a matter of being as personal as possible. I think with each facility that we reach out to. And again, as we start to hopefully keep on rolling with recognizing facilities, we think a lot will um, kind of follow suit. See what we're doing, get the word out. Some of our applicants are part of hospital systems in Ohio that have 20 or 30 different emergency departments across the state. So that's another piece of it as well. We see in terms of hospital recognition, if we get some of these systems on board, one of their facilities does it, they're going to want all of their facilities to do it.
What other questions do you all have for Kyle? Well, thank you again for sharing, Kyle.
Yes, thank you. I
Excited to
appreciate it.
hear about the progress that you all have had in the last couple months.
Thank you.
All right, next up I have Pennsylvania. Dwayne, if you'd like, I can share the slides, or if you would like to share your screen.
No, yeah, I'll just have you advance.
All right.
How it works, by the way.
You
So
can
good
take it away.
afternoon, everybody. So I've got kind of a split here, sharing both our ED program that's under development and our pre-hospital program, which went under a huge review and revision from the program that was in place back in 2013. Any information about either program is at our website there, and I'll put that in the chat as well. So the ED program, actually, we started back in June of 23 with a steering committee, and that the first 9 months or so was developing a kind of an outline of the program. We met monthly. It's a representative team of people from hospital associations, pediatric physicians, general ED physicians, ENA, and other stakeholders that had a kind of a view and a place at the table. And we got pretty far along with that steering committee, but what we realized was we needed to have the input from the end users, the stakeholders that are going to apply this program. So we started developing a pilot group of representative hospitals from across the state. We put an ask out in January of 24, and we got a slow response to that, but over the course of about 4 or 5 months, it increased, and I forget now, 10, 11 facilities, including a children's hospital, a level 1 trauma center, community access hospital, general community hospitals, hospitals that were part of a large health system, hospitals that were independents or small 1, 2, or 3 type hospital health systems. So we did get a pretty robust representation of capabilities, needs, geographics from across the state, to provide input on further developing the program from an outline to a final program. The process as of the beginning of November is we submitted it to our advisory committee in September. We're reviewing it again the end of this month for approval, and then it has a process within the state for recommendation through the EMS advisory board, to the Department of Health, and looking to have something with a go live of July 1st of 2026, with all things going well. And this year is a good example of how things don't go as expected. Next slide, please. So our program was established and outlined to the 7 focus areas. And if you remember, these are pretty familiar to some of us way back in the beginning of having a PEC, having specific policies and procedures, having additional equipment, supplies, and medications that are part of that ED checklist, including policies and practices on patient safety and family-centered care, addressing care team competencies, ensuring that there's a quality improvement process that includes PEDS, and then having good communication and collaboration across systems of care, both within the facility and externally with other stakeholders, such as EMS. Our pilot phase was established to really refine those requirements for the focus areas to make them workable. We can put everything we want on paper, but if it's not can't be applied and difficult to be applied, or overbearing and too much effort, it's not really a good program. It's just paper. One of the big changes we came up with, we had 3 levels, but actually we only have 2 tiers. The 2 program tiers are just that, tier 1 and tier 2. The 3 program recognition levels, which haven't been named yet, take tier 1 as a standalone, but then split tier 2 up to the requirement for the PEC being that of both the second and third recognition level, but only requiring a 50% compliance with tier 2. And that's really at the hospital's capacity. So of the 6 remaining focus areas, they have compliance with 3 of them to meet the middle recognition level, and then the third recognition level, they're compliant with all 7 focus areas in tier 2. As was stated from my predecessors, we're using our advisory committee for feedback and approval on the recognition application. It's not just someone like myself saying, yes, you're approved. We kind of follow the line with what our Trauma System Foundation does, where there's a presentation to their board. It'll be a presentation to our advisory committee, EMS for Children Advisory Committee, for feedback and approval of the application once we've gone through all the steps. Next slide, please. So as this, it's still kind of in the finalizing the pilot phase, we wanted to look and see what our enablers were. And as I said, we had a very representative, engaged steering committee, a lot of good feedback, a lot of cooperation with, working through some of the components to address questions or concerns. And then adding to that a cross-sectional representation of facilities in our pilot during the development stage. Those pilot facilities are going to have first chance at application once the program is approved, and it's going to help us also pilot some of our documentation and review process to make sure that we kind of bug it out before it goes fully live across the state. Support within the state has been through our hospital association, through the Trauma Systems Foundation, which Pennsylvania is a little different. It's not per se ACS. It's been this way since the 1980s, but it is very robust Trauma Systems Foundation. And we have over 47 or 48 trauma centers of level 1 through 4, and they go through a reaccreditation cycle every 3 years. The Pennsylvania College of Emergency Physicians, PAENA, the Department of Health has been very helpful with feedback, our Bureau of EMS, and specifically also our Bureau of Preparedness, both from the Bureau standpoint and from a contractor standpoint, who help support emergency preparedness across healthcare with the healthcare coalitions, have been very interactive with supporting the development of our program here. Next slide, please. Some of the barriers we've come across, and I kind of just highlighted a few. There's been many, and each has a little bit different complexity, but the complexity of healthcare delivery across the state has become a barrier in the sense that it was mentioned earlier, we've got some health systems with multiple hospitals, upwards of 30 for one of them, and how that health system may want to, as Kyle just said, all their hospitals be PEDS ready. That's, if those applications all come in at once, it's an impossibility for our program and our resources to be able to process. So we're going to ask that not happen, but that I'm sure is going to be the effort. If a health system wants one hospital to be PEDS ready, they're going to want them all. There's some financial constraints been expressed in the cost to do business in general. Is that the equipment? Is that the time dedicated to PEC level or other components that it's unreimbursed? And with healthcare costs and the profitability of healthcare being strained, there's a lot of concerns about, is this something that they want to invest in, and what are they going to get out of it? We're working with Department of Health to develop some language coming from them in support of the program when it goes live, so that it has a little bit more oomph in it than just, hey, we want you to be, you should be pediatric ready. We have seen some pushback from health systems in implementing a individual PEC. They want a health system-wide PEC, but I think we all recognize the importance of having a local individual in support of the local needs and the staffing there. But even at the health system wide, identifying it back, again, it's an individual, what's the effort that they're going to um, receive from it by implementing something. They're already receiving these patients. Why do they need to do anything better? And we have to be more demonstrative of outcomes, the net improvement of care and why they should. You got to explain it to the bean counters, not to the clinicians. And the reality is in Pennsylvania, there is a limited oversight of the healthcare delivery system. Department of Health has some oversight, but it's more of a regulatory things are already established in law and not so much a clinical support structure. So we've got to use the Department of Health to get to the C-suite and get to the hospital leaders to get them to buy in. And we're also going to use our hospital system, who is very engaged with the program and with our EMS advisory board to help communicate that. They're the ones that helped us get the pilot facilities on board, and they're, consistently is supporting us with the delivery of pre-hospital effort. So we expect to be utilizing them heavily on getting the word out to engage hospitals with education and knowledge about the program. Next slide, please. So our next steps, as I said, we rolled this out to our advisory committee with our annual in-person meeting in September. We have a review and discussion set for the end of this month, with approval expected based on the feedback I've received so far of the program outline to be then sent through our EMS advisory board, since our EMS for Children program sits within the advisory board. And then that pushes out via a process that's pre-established for Department of Health approval. With the way it went with our pre-hospital program last year, I expect that, sometime early Q1 of next year, I would see that feedback from the Department of Health. And once received, we'll continue to work in earnest to develop program documentation, so applications, handbook, talking about what the program is, what in each of the tiers are, what the responsibilities are of the applicant and the application process, as well as the site visits and things like that. We're going to use, I said, our pilots to kind of test drive that towards the end of Q2 of next year, and be able to have some revisions as necessary to our program documentations by the end of June, so that we can roll this out with statewide communications beginning July of 2026. We use this timeline. That's what our pre-hospital timeline was for last year, 1 year ago, and it worked fairly well. So hoping that we can mirror this with the hospital program as we continue to develop it. Next slide, please. So our EMS program, at this time last year, was getting its final approval at the EMS for Children program in taking a 5-level legacy program and refining it down to 3 levels. That was somewhat of a suggestion by both HRSA and our own internal review team, but also adding the national targets that were developed out of white papers and other recommendations. So the key was to integrate those additional components and develop a progressively increasing and engaged program that addressed accountability. That if there was one piece of feedback I got since starting in my position in January of 2020, was that people didn't feel there was accountability of our legacy program. The review of the program was designed to meet the HRSA standardized requirements. I say that in that it's a minimum to meet the standards. We have gone above that in several cases. We've included child passenger safety in all levels. It's optional in the first 2, and it's a requirement of the 3rd level, as it was a component of our existing legacy program, and we felt the importance of safe transport both in an ambulance and in motor vehicles was key to both, the care of a child and preventative care, outside the EMS environment. So, like I said, we look to develop that implementable and a sustainable solution, not just something that was on paper. We worked with a team a review team that had agency and PEC leadership, feedback from them, uh, um, and we wanted to make sure that we evaluated the cost of the program at each of the agencies' levels. So most of the cost was associated with the additional equipment, although I think we were in a good position that our statewide equipment list based on licensure level didn't have a whole lot of extra items, and the ones that were extra weren't on the required list, were probably carried. Some of them that are on the required list are optional in Pennsylvania, so they became a requirement. Things like the check and inject for epi is an optional at the BLS level because it's fairly new in Pennsylvania as part of a scope issue. So we just rolled it in order to be pediatric ready, you had to have the components to be able to, address the pediatric delivery of epinephrine. Um, those costs actually were higher at the BLS level than they were at the ALS. Uh, but per ambulance, they were under $600 total if you didn't have any of the equipment. And in sampling out some conversation with people, many of the agencies had much of it. So we didn't think there was going to be a significant impact on cost there, but it was a consideration. And the last thing we did was we integrated it into our triannual agency relationship process. So their recognition renewal date will coincide with their licensure renewal date. And that'll help with equipment verification because it'll be done during the relicensure process. But it also give them, the timeline that, hey, when's my pediatric date? When's my licensure date? And they can just keep a calendar for one specific date as they go through. The state has divided them up so that it's fairly equitably divided across 3 years and 4/4 of 3 years. So it also hopefully will reduce some of the effort on our end for programs and renewals that we're not going to have everybody in 1 year and nobody for the next two, things like that. Next slide, please. Our application process, and I'm going to put a link in there in the chat, but everything is available on our website with the exception of the actual application. And I did that on purpose so that we just didn't have people sending an application in. The goal was to begin communications with an agency right away. So the letter of intent is just that. It identifies the agency and an authorized individual from the agency has said, we want to apply for this, and here's your primary contact. And they then, submit that, and we can begin to have communications. They can ask questions. We then provide them with all the digital documents that are available on the website, and they can start the process. Of the applicants I've received so far, 11 are in different phases since July 1st of this year. But of the agencies who are moving forward, there's been a lot of questions. It's a new program. I wouldn't expect anything less. But the questions, from a QRS, non-transporting first responder unit, they don't understand performance improvement as well. So we're actually developing a performance improvement document to help them develop a PI plan and implement performance improvement at their level, something that most all of those QRS services have never considered in the past. The application itself, once it's submitted, goes through a review process. And if there's anything missing, it's sent back to the agency for revision and resubmission. And that's happened on 2 of the applications so far. They didn't have complete documentation submitted, they were missing a document, or a date, or information wasn't clear or correct. And we do schedule a site visit. Our plan is in-person site visits for all new and virtual site visits for all upgrade and renewals. And with the plan for um, having in-person site visits, there is the challenge, just like Kelly said, one person or a small team across a large state. Doesn't take me 12 hours, but in one corner of the state, it takes me 6+ to go to the other corner. So there is some challenges that we're working through, getting people from the advisory committee or PECs from areas geographically more central to specific parts of the state to assist with an in-person site visit to minimize some of the travel, increase the number of people who will be part of that team, broaden some of the diversity of the team itself to do in-person site visits. Once the site visit's done, there is going to be a review team that virtually will do a full review of the application and site visit results, and submit a review to the advisory committee for consideration and approval. As I said previously, this is kind of in line with our Trauma Systems Foundation process, where it's a committee that reviews and approves it, and not just an individual or a small team. With the advisory committee only meeting quarterly, there could be some delays in time from application to site visit to approval, but that's inherent, I think, with anything that has any substantial qualifications. The Trauma Systems Foundation, it takes over a year of process, so I think it's acceptable. As I said, 11 applications in various phases of letter of intent or actual applications have been submitted and is under review or is under revision by the agency for resubmission. Next slide, please. So the verification process and pretty much how we go through it, I've touched base on, but I'll just address a couple things. A letter of intent is that approval by the agency to apply. I did previously receive applications for a legacy program that agency leadership had no idea were being submitted. We have that application review and submission process, the hard site visit, whether it be in person or virtual, will also include an invitation to one of our 13 regional EMS councils. They're the ones that are more locally responsible for supporting EMS agencies. When they do EMS licensure, the regional councils have that responsibility. So they're engaged with that agency more than the state EMS office, just the way Pennsylvania's developed there. That committee review post-site visit, and then a recommendation up to the advisory committee report of what the committee feels should be handled with, or how the committee feels the site visit went. And then, with the advisory committee determination, notifying the agency, providing them with some media support, and expressing our own media contact through social media and some other components as we're continuing to develop that. As of right now, we do not have any verified. As I said, we started in July, and to be quite honest, with some of the challenges that occurred with federal and state budgets, our state budget got approved a week ago. And so we've had a little bit of funds delay, and therefore our processing of applications was delayed a little bit with that. Next slide, please. This was mentioned by one of my predecessors. There are a lot of ways to communicate information along with our web presence, which we do have direct control over, and I think that's a great benefit. I revised the entire website last December, and I give updates to a web developer to put on there, and I can do it myself. I'm not an expert on it. It's a lot easier for me to give the information to somebody else and they make it happen. I think it looks better. It's attractive to people. They want to navigate it instead of they look at something that is difficult for them to visualize and they skip off of it. But we do utilize several different email lists and licensure contacts. As Kelly said, we have access to all the EMTs and paramedics through a listserv, but we also have all access to all the licensure contacts for EMS agencies, and they're only as good as they were when they were entered into the licensure database. With a change of people, I do find I get a fair amount of bounces. With that same database is all the medical directors for the organizations, and contacting them independent of that and with a little different communication language, I think has been very beneficial. With the pre-hospital program, we actually sent postcards out to all the postal addresses for the licensure, the EMS agency, and made them aware of the program. Heavily used on social media, but targeted mostly at Facebook. We've been at multiple conferences and will continue to do with that. We utilize our regional EMS councils to distribute out however they would, with newsletters or just, postings or conversations and meetings, stuff like that. Our Bureau of EMS has a monthly EMS roundtable, and we were the highlight of that roundtable earlier this month. And then utilizing our affiliate stakeholders via our state EMS advisory council. The council is representative of EMS agencies, hospitals, training centers, other stakeholders that are part of the EMS system. And so we can express communications about both pre-hospital and ED program through the stakeholders for the EMS advisory council. I think, a lot of challenges came out of trying to meet the minimum requirements of the standardized program, but also meet the needs and the capacity of EMS agencies and also EDs, that one size doesn't fit all, and what works in Pennsylvania may not work in Ohio and vice versa. That it's important to really work within your state and your state stakeholders to make the program something that's accessible, that's sustainable, and that you can implement and will have a durability to it, not just, as I said, paper. And that's what I have.
Thank you so much, Dwayne, for sharing an update on both the work on your ED and pre-hospital recognition programs. I do see there's a question in the chat for you, but also in the interest of time, I might ask that we manage that in the chat. And if there are any other questions for Dwayne, maybe you can address them there so that we can give some time for our colleagues from Puerto Rico to share an update today. I think we have Wanda on today to share an update. Like you're still on mute. Yeah.
Hi, you can hear me?
Yes. Yep.
Yes. Well, I am Dr. Martin. Hello. Nice to be with you this afternoon. Wanda is over there. So
Welcome.
yeah, we are from Puerto Rico and we have a very nice weather here. So you're really, you can come to visit us. So Casey, you can pass that. Yeah. Okay. Well, we are in the baby step. We are in the recognition program, the phase of development. So we are starting this phase now, and we establish a pilot project selecting 10 hospitals in base of geographic area of the health regions in Puerto Rico, and basis on the 2021 NRPR assessment results. And we have discussion of developing recognition program, including building a core team, invitation to hospital to participate in the project, letter of commitment, presentations, and complete consents for participating in the pilot program. The pilot program project has the support of the Secretary of Department of Health and the Puerto Rico Hospital Association. Next. Here is the the map of Puerto Rico. Puerto Rico is an island in the Caribbean, and we have a, how can, you have to pass the host. We are going to show, I am going to show you, you can pass all them. They are 9. I'm going to show you where we get the hospital. They are across around all the island. In the north, we have in Fajardo, in the northeast, and Humacao. I don't know how they have some missing letters in the name. I don't know why. In the center, we have Caguas, and in the south, we have Ponce, and in the east, in the west, we have Mayagüez. In the center, in the Cordillera, we have Lares, and in the north, we have Vega Baja. We also have 2 hospitals in the area of Bayamón and 1 in Carolina. This is a complete our 10 hospitals that were selected by the volume of pediatric patients they saw. They have to be low or medium, and by according to the regions of different regions in Puerto Rico. Next, please. Yes, the process, we are the working committee that we are part of the EMSC personnel, Maria Esther Centeno, Wanda, and Leslie Ann Soto is from the Department of Health, and Dr. Yacel Gonzalez is a pediatrician working here in the pediatric hospital. And the application process is free and voluntary for all the hospital. We invite the hospital to participate. We send them letter of commitment, and they have to complete a consent form from the CEO or administrative person in the hospital. We are planning the verification process going to be on site. We have the checklist for the verification, and we have participants from the Puerto Rico EMSC, a Department of Health, and Hospital Association. The recognition overview, the recognition tiers, we have only 2, according to the regulation of the Puerto Rico hospital law, that has the secondary level 2 pediatrics ready. That the secondary level is a hospital that has a pediatrics, internal medicine, and OB-GYN, but don't have a PQ. Only a general ward of pediatrics. The specialized tertiary level is a hospital that has subspecialty in pediatrics, have pediatric surgery, and have a PICU unit. But in this sample, this pilot project, the only hospital that we are going to address are going to be level 2. Next one. Okay, I told you is the process voluntary through the survey integrating NRP guidelines and hospital licensing and certification regulation. And we have already the commitment of the Department of Health and the 10 hospitals, and the commitment support of the Puerto Rico Hospital Association and other stakeholders. Next one. This is part of the neighbors that we have, the recommendation made by EMSC Advisory Committee on how to achieve a better response from hospital administration, the benefits of participation of the PRRP collaborative, support of the Department of Health, MCH, and Hospital Association, AAP, and ACEP, and Pediatric Association and Pediatric Champions here in Puerto Rico. And we have also the chapter 21, is a chapter emergency department from the Hospital Regulation 9181. Next one. So these are our stakeholder association in Puerto Rico that they are all on board, looking forward that this pilot project is going to be in place. Next. Barriers, as somebody told us, the bureaucracy in the politics and lack of funding, cost versus benefits, instability of the health system here in Puerto Rico depend on maybe of the mainland, and access and communication and projection to community and children and family. Next. Así que our next step we are finished the verification instrument that we are doing, but we have complete signed the consent from 5 hospital already signs the consent. We have only the other 5 hospitals pending to complete, but they told me that they are on board, so they are pending to have the approval of the CEO of the hospital. But they received the Pets Ready project with this very nice, and they think they're capable of start the project. We are pending send the survey, and the survey must be completed in 2 months. And then when we finish this, we are going to get the gap report of the 10 hospital, and we start the reunion with the advisory board and start the verification process in site visits in all these hospitals in Puerto Rico. So this is our plan. Next one, I think that's the last one.
Yeah.
Any question?
What questions do you all have for the recognition program out of Puerto Rico? Dwayne was wondering if we might be able to get a copy of the consent form you're using. The ways some.
Okay, we can send a copy. The copy is in Spanish. Do you? The copy in Spanish, but we are ready. We can send the copy.
I know somebody, they can speak it to me.
Okay.
I'll put some translation. Right. Okay, any other questions? Thank you so much for sharing what
to
you guys
you.
have planned for your recognition program.
Yeah, thanks to you.
We have just a few minutes left. I do want to share some updates with you all from the last year, as today is our last exchange session. So thank you all for continuing to be a part of this work with us and sharing updates and supporting one another in your efforts to develop or enhance your recognition programs. So we did want to celebrate, there's been a couple new recognition programs over the last year. So we have newly established ED programs in both Maryland and Georgia, and then newly established EMS programs in Oregon and Florida. If I have missed any states who have a newly established program in the last year, you're on the call today, feel free to put it in the chat so we can also celebrate that work. The remainder of my slides, I think I will send by email, so you all have some time to review them. I wanted to share with you some progress, also go over the feedback you all provided to us about the exchange and what you hope to see in the coming year. We took all of your feedback and with that in mind, put together some possible topics for future sessions in 2026. So I will send those to you all by email so you have a chance to really review them and provide some feedback to us on those as we plan for next year. So we look forward to continuing our sessions on the 3rd Thursday of the month, starting again next January. So we appreciate you being on today and hope you all have great holidays. We'll see you next year.
Thank you.
Thank you all.